Well, we had some guy calling in the cars, cutting out catalytic converters and stuff. Couldn't tell me what to do.
All right. So a couple of things that we didn't get to on Wednesday, just ran out of time. Mindy was going to have my high if I ran too much longer. First off, if you had an opportunity to look through the textbook, central ray location. Central ray location is pretty much most of the images, with the exception of PA axial, is going to be at the angle of the ribs. L1, L2. The easiest way in a lot of cases to find that would be it pretty much corresponds with bend of the elbow. So just have the patient kind of bend their elbow and that'll get you close enough to it. So the things that we didn't talk about were small bowel series. And a small bowel series is just a series of KUBs essentially. So small bowel picks up on page 237 and usually, or often, I won't say usually, a lot of times we do a small bowel series all by itself, but sometimes it follows a upper GI. So sometimes your exam is esophagram, upper GI, small bowel follow through. And so after the upper GI, what we'll do is we'll give the patient some thin barium, usually a couple of cups of thin barium, and then it's just a series of essentially KUBs until it gets to the ileocecal valve. Your first image, like what you're seeing on page 237, is usually kind of like a KUB, but it's taken a little bit higher. Like again, you're going to center around L1, L2, and that's essentially to make sure that you get the fundus of the stomach. Okay, and that first image, if you're just doing a small bowel all by itself, in a lot of cases, that's going to be at 15 minutes because essentially it doesn't go anywhere. It doesn't go very far anyway. In that first 15 minutes, so you have a patient drink a couple of cups, wait 15 minutes, take kind of a high KUB, take a look at that, and if it hadn't gone anywhere, then your second one may be high as well. But pretty much everything, in most cases, everything after the 15 minute. Certainly after the 30 minutes, just going to be KUB until it gets to the ileocecal valve. So, pathologies, we didn't really look at pathologies on Wednesday, did we? No? Okay. So before I do pathology, let's take a look at one other thing, and that is on page 239, enterocolitis. So enterocolitis is the closest we can get to a double contrast exam of the small intestine. Can't really do air contrast, so we do what we call enterocolitis. And it makes for a beautiful study. You see the images down there at the bottom, and you can see the mucosal lining really, really well on an enterocolitis. You can see the feathering of the small intestine. But the double contrast is between two different liquids, one being a barium sulfate solution and the other one being what you call methyl cellulose. So your part in an enterocolitis, in most cases, a PA, an RA, or a radiologist is usually doing the exam under fluoroscopy. And what they'll do is they'll put an NG tube into the patient, and you'll have between 4 and 8 cath tip syringes so that the radiologist or the PA, whoever's performing the procedure, can inject this stuff. So you'll have two different basins, one with barium suspension and one with methyl cellulose, and you'll go ahead and draw the liquids up into those syringes, and your job is to keep the syringes full and hand them to whoever's doing the procedure. And they'll hook it into the NG tube and inject it. So, I think the textbook says something like they'll inject in sequence, or what the sequence is basically, give me this because I did that before, so let me have the other one. So you have two different basins, one with the barium and one with methyl cellulose. You just suck it up into the syringe and just hand it to them, and as soon as they inject one, you suck up another syringe full. The methyl cellulose gets real slick, so be aware of that if you ever have to do this. Loop your your hand or your, either a finger or thumb over the part of the syringe that you lug your fingers into to inject, because if you don't, it's just gonna slip right out of your hand. It's really, really slick. So it's kind of messy, but it gives a really, really good study of the small intestine and mucosal lining. And again, that's the closest we're gonna get to a true air contrast quality study of the small intestine. So running through pathologies of the upper GI, we got a lot of different pathologies. We have ulcers. We have ulcers in the stomach. That would be a peptic ulcer. We have duodenal ulcers. So this is the distal portion of the stomach, and we're into duodenum here. For the reasons that we'll talk about it when we get into the next section, the GI and GU, we'll talk about the duodenal ulcers. Free air, not really so much. What we're looking for is free air, but free air can be a complication of an ulcer. If you've got a perforated ulcer, then you can have also free air as well. Hiatal hernias are definitively diagnosed with a GI study, but a lot of times they're incidental finding. A hiatal hernia is basically, it's mainly a congenital condition, but it's basically where the esophagus plugs into the stomach. It punctures through the diaphragm. That orifice in the diaphragm can enlarge. And what happens is a portion of the stomach comes up above the diaphragm. And it can be what we call a rolling hiatal hernia. That means that it goes up and it comes back down. It goes up and it comes back down. And sometimes it's difficult to diagnose. So what we'll do in the procedure in some cases is, this does a couple of different things. We might put the patient in Trendelenburg. Alyssa, could you grab the door? Thank you, ma'am. But we'll put the patient in Trendelenburg, and that forces the barium that's feet above the head. That forces the barium into the fundus of the stomach, and that would possibly force the hiatal hernia above the diaphragm. The other thing is to have the patient in a prone position or possibly an RAO position for the patient's comfort, and put a roll, like a rolled up towel under the patient's stomach, and that just increases abdominal pressure and does the same thing. Okay, so hiatal hernia is usually follow-up after they've done a chest x-ray and the patient looks like they've got this big air cavity directly over the heart. It's generally a hiatal hernia. So this would be significant enough that this is pretty much what you would call an intrathoracic stomach. The entire stomach is above the diaphragm, but it's a hiatal hernia. It's just so big, the whole stomach is up there. So we have also atresia and stenosis, and that is usually in pediatric patients. So you've got a baby, you got a couple of different things. We looked at esophageal atresia on Wednesday, right? So if a baby tries to drink milk or the colostrum, that they get during breastfeeding initially, and it comes directly back up immediately, that's an indication the patient may have esophageal atresia. It just doesn't go all the way into the stomach. But if it goes into the stomach and it sits there for an extended period of time and it sours, and then the patient usually projectile vomits because the milk is soured, that's a good indication the patient has atresia or stenosis. Stenosis just being narrowing. So that again is in kids, little babies. Just basically a KUB. We can tell that this is past the ileocecal valve because this is a characteristic appearance of the large intestine. Okay, so we'll look at that here in a bit. You'll be able to see the look of the large intestine much better. So pancreatic cancer, I talked about this on Wednesday. The C loop of the duodenum is much enlarged. That indicates the patient has a cancer in the head of the pancreas, and that's just bad news. And diverticular, very common. See these little things here? We talked about the Zinker's diverticulum on Wednesday. but diverticula can occur anywhere, and we usually associate diverticula with the large intestine. You'll hear them referred to as tics. So just outpouching anywhere in the small intestine, a very common, or anywhere in the GI tract really, but a very common small intestine diverticula is what they call a Meckel's diverticulum. And it's kind of like a normal variation, and it's, what is it? There's some fetal, it's a fetal remnant of some attachment that should kind of seal up, so to speak, after, you know, the umbilical cord's cut and all that. And in a lot of cases, it's also a incidental finding. Patient didn't have any kind of problems with it or anything like that, but on a small bowel follow through, they may see an enlarged area right at the ileocecal valve, and that would be indication of Meckel diverticulum. Okay, so we looked at that. That's atresia. It's completely gone. Disconnection between the duodenum and the small intestine. Crohn's disease. Crohn's disease is basically colitis. All right, so you got ulcerative colitis and you got Crohn's disease. Crohn's disease can occur in small intestine. Generally, when we're talking about ulcerative colitis, that would be the equivalent of Crohn's disease in the large intestine, sort of. Okay, so any questions on that? Thomas, can you see a table back there? Okay, there's a high voltage, yeah, don't lick it. No, it's not connected to anything. A high voltage cable, see if you can pull that and let me have it. See if you can get that out of there so I don't have to trip over people.
Where is it down here?
No, it's on top. That big white cord. Yeah. Yep. So I'm going to use this for demonstration purposes. This is not going to be a high voltage cable. It's going to be a cold. Thanks so much.
Yeah.
All right. So large intestine, again, we can do single contrast, we can do double contrast. Single contrast is just going to be barium unless otherwise indicated. The patient has a suspected bleed, a perforation, probably going to use gastrography and something like that. But if not, then we're going to need to use barium, right? Preferred barium. Again, you know, if you find yourself working in a hospital that just does gastrography on everything, follow protocol. You know, it's their procedure. They're paying the bills, they're paying the lawsuits. You know, you do what they say, right? But most hospitals, barium's going to be your go-to. So maybe one stage or two stage. We'll talk about that here in a second. But the two stages is in some cases the way air contrast is done. All right, so most of the time it's going to be barium for the same reasons we use barium in the upper GI system. All right, preparation, very similar to preparation in the upper GI. Minimum is going to be NPO after midnight, probably NPO after the evening meal, possibly some laxatives, possibly an enema before the patient comes in. I worked in a hospital where, you know, if there was any kind of fecal matter left in the colon, they completely canceled the exam. So that's kind of rough, but that was their protocols. So all of that. So you've got two different types of BE setups, and you can tell the difference between them by the appearance. You've got the air contrast system, and you've got the solid column. So solid column usually comes with a barium in it, and you know, not mixed, but the powdered barium in it, and you put water into it, you mix it all up, and it's got a single tube that comes out of the bag, and you put an enema tip on that, and you're set up, right? The air contrast is a little bit different. The bag usually comes empty, and this is in my experience anyway, the bag usually comes empty, there's nothing in it, and you've got to pour the barium into it. All right, you may have different setups. But what you also have in those cases is you've got a different tip. All right, so the tip has it's basically got 3 tubes going into it. Okay, so single column has 2 tubes going into it. Right, one big tube where the barium goes through, and then one small tube. The tip of the enema tip has a balloon on it, and it's a retention balloon. So you put this thing onto that smaller tube in order to inflate that balloon so that it remains inside the patient's rectum. Okay, so you put the tip inside the patient's rectum, you inflate that balloon, and that balloon holds it into the rectum so the patient hopefully doesn't pass it out. It happens sometimes anyway. The double contrast, though, not only has that tube, the big tube for the barium, a small tube for the inflation of the enema tip, but it also has another tube that comes off of it, and that tube is what you hook a second bulb to inject air through the enema tip. Okay, so single contrast has 2 tubes, a big tube and a little tube. The double contrast has 3 tubes, 1 big tube and 2 small tubes. Okay, so you can tell the difference between those setups. So in both cases, I got a retention tip to hold the tip into the rectum. Okay, so with that, what are we looking at here? Ignoring this up here again, how many places do you see available for a tube? You got 1 tube here, you got 1 there, and that's where the barium goes in. So it's a double contrast enema tip. This would be the one that you would hook what looks kind of like a blood pressure inflation bulb onto it. And this, in a lot of cases, is just a single squeeze square little pad looking thing. So you squeeze it, clamp it off so that the enema tip can't deflate, and it helps to hold the enema tip in again. So other things that you're going to need, if your hospital buys these things, then use them. They're a lifesaver. If your hospital doesn't use them, then if they don't buy them, then you're going to have to use a lot of towels. Okay. Even though we have a retention tip on the enema tip, there can be a lot of leakage. The enema tip can deflate and come out. Remember that most of these patients are sick. Most of them are older patients. They just don't have muscle tone they used to have, right? And if the enema tip comes out, they're probably going to lose some of the barium. So what this is, a lot of people refer to it as kiddie pool because it kind of looks like a kiddie pool, right? But this you put under the patient's hips, and you can place it before you inflate it, but put it under the patient's hips so that their butt is right inside of this thing. So this is attached to that bottom plate, so it's fairly leak proof. Okay, but if you put it under the patient before you inflate it, you can inflate this with the O2 tubing that's in the room. Okay, just run the O2 tubing to it, hold it tight, turn the O2 tubing on, and it will inflate it. Okay, so if you have a patient that's able to participate, certainly you can inflate it before you put it underneath the patient. But if you patient can't really participate that well, place it, inflate it with the oxygen tubing. That'd be fine. This is just a little clamp to make sure that the air doesn't come back out of it. Okay. So the purpose for this is that if the enema tip comes out or the patient leaks around the enema tip, this is going to catch the contrast. Okay, the problem with contrast and leak out on the table is if the contrast goes inside of the table and drips down onto the X-ray tube, then there's going to be an artifact on every image that you create, every fluoro image, until they take that table apart and clean it off. Okay, so if it goes down inside, it's tough to clean up, right? How many times have you tried to pour something out of glass and it comes out of the glass and it goes down the glass a little bit before it, yeah, same thing can happen on your table, okay? So if you don't have these, then you're gonna have to use a lot of towels. And you know, if you've got a young patient that's, you know, looks like they're still in pretty good shape, you might not need these. But if you have an older patient, you're gonna take those towels and you're just gonna build a levee, essentially, going up under their legs and all the way up to their waist, okay? If you find yourself in a position where, you know, after a few years you're in charge of ordering, get these, okay? They're great. And I don't know how much they are, but they're worth the money, all right? So, plenty of towels, or, you know, get some of those. Well, that's it. So, the reason we require leather shoes in part is because of barium enemas. You show up in Crocs that have those great big holes in the top of them, or canvas top shoes, and that barium's gonna go right through them. Okay, blood's gonna go right through them. If you drop a syringe, it's gonna go right through it. Okay, so could it get through the leather shoes? Yeah, it could. But you know, if you're wearing something that's not leather, then it's gonna go through a whole lot easier. You know, certainly not sandals, but it's gonna go through a whole lot easier than if you're wearing leather shoes. So, you know, wear real shoes. If you're wearing clogs of some sort, just make sure that they don't have those great big holes in them. Okay? So preparation, let me say this real quick. Preparation, if you're using a system that you have to add the water to the powder to mix it up, then you're gonna have, there's a logical, you know, process that you're gonna go through. What would you want the temperature of the water to be?
Room temperature.
Room temperature, maybe even warm, right? You don't want to put something cold inside of the patient. It's counterintuitive, but you want it cold. Okay, some of your hospitals will actually keep the barium inside of a refrigerator. So, you know, if you add warm water to the patient's bowel, they're going to have an increased tendency to lose that barium. Okay, it's going to potentially put their stomach in cramping, and they might lose the barium. So if you put cold water in, or cool water, not going to be ice water, but if you put cool water inside of the patient, then it has a calming effect on the bowel. Okay, so resist the urge to make it warm. You know, you're not making a bottle for a baby here, so you don't need to sprinkle it on your wrist or anything like that. Keep it cool. Cool tap water should be fine. Okay. So let's get to the procedure itself. All right, so enema tip insertion. What we're going to put the patient in is in a SIMS position. That's basically an RAO position. So what you're going to do is you get the patient into the room, get them dressed, put them in a gown, tell them to take everything off. You know, because if they leave their shirt on and buttons show up, or you know, if they've got paint or maybe a sweatshirt or thick clothing, it can cast an artifact. So have the patient just completely disrobe, have them in a gown, cover them up, right? You roll them up into an LAO, I think it said RAO, but it's an LAO position. Put the right leg in front of their left, pull the sheet back, you know, to expose the part that you need to expose, and tell them what you're doing. Make sure you use plenty of the lubrication. Tell them what you're doing. Tell them take in a deep breath, blow it out, and insert the enema tip. Just go in. You ever had your blood drawn by somebody who was a little new and they kind of hesitate a little bit? Kind of same situation here. Just go in with it. At some point, the bowel will take the tip from you, right? So what you'll find if you haven't done any kind of enema tip insertion is you push it for a little ways, then all of a sudden the bowel has a tendency to pull it away from you. All right, so it's going to go in as far as it should go in. Some of your doctors, especially, don't want you to inflate the enema tip until they get into the room. So be aware of that. and follow procedures. The reason for that is because a significant number of colon cancers occur at the rectum and anus, or really the rectum. And if you inflate the enema tip and do some sort of damage to the rectal wall and then put contrast in, especially barium, it can create problems like what we talked about before, right? So know what your hospital protocol is. I've never seen any of that happen, but it theoretically could, so some of your doctors don't want you to do it. Okay? So SIMS position, enema tip insertion position. Once you get it inserted, roll the patient back, onto the back, flat on their back, making sure that the enema tip doesn't come out. Okay? Cover them up, cover them back up, and call for the doctor. All right? So the IV pole need not be more than about 24 inches above the tabletop. The reason for that is because the higher it is, the higher the pressure is. Okay? So if you put the bag, all the way up to the ceiling, then the pressure on all the barium inside of the bag and inside the line increases. So if the patient, again, has a weakened bowel, it could cause a rupture. So no more than 24 inches high. All right, so some of your radiologists, I've seen radiologists grab that bag and squeeze it to increase the pressure. That's their insurance, you don't put it any more than 24 inches above the bed, okay? And before, any more than 24 inches above the table, rather. So if the radiologist wants to increase that height, that's on them. You don't do it. Okay? So all that on enema tip insertion, single contrast. So make sure you get a good history on a patient, right? So you may have an order from the doctor, the patient's referring physician calling for a barium enema, and then you find out the patient's got significant bleeding. That's information you need to pass on to the radiologist, right? So make sure you pass that information on. They may switch it from a barium enema to some sort of iodinated contrast. So make sure that you communicate that information. You get that information from the patient, communicate it to the radiologist. Sometimes the radiologist will show up and they'll have to, they'll kind of duplicate everything that they just said. But sometimes docs show up and they just don't talk to the patient very much. So you make sure that you do your job and get the information to pass on to the radiologist. All right. So what's going to happen is you're going to, the radiologist or the PA comes into the room, and your job at that point is going to be to turn the barium on, turn the barium off. So the radiologist, inflate the cuff. Might do it under fluoro, inflate the cuff, and the radiologist will say barium on. So what your job then is to do is to unclamp the barium so it can flow into the rectum, right? So when you're making your barium, what you want to do, it's got a kind of everybody's seen a barium setup? Has anybody not seen a barium setup? Okay, there's a little clamp, it's just a little slide clamp that pinches off the tubing, okay? Make sure that clamp is out from underneath the patient. Make sure it's out far enough that you can get to it without having to get up under the patient's covers, right? In order to turn the barium on, turn the barium off. And when he says barium on, that's just open the tube. Barium off just means close it, right? Clamp it off. So that's what your job is going to be, is just make the patient comfortable, keep the patient covered up, barium on, barium off. The radiologist will roll the patient around, take some spot images, and when they get ready to leave, you'll just ask any overheads. And if they say yes, then that's where we're going to spend, this next 20 minutes or so. Overheads. So what we're going to do with overheads is single contrast and double contrast is going to be a little bit different. We'll back up and talk about the end of the procedure here in a second, but the exams for the images for single contrast will be an AP, an LPO, an RPO, an AP axial sigmoid, and some of our hospitals in this area like to do what they call LPO sigmoid. You can do a Google search on LPO sigmoid colon, and you might find some internet references, but the best I can tell, it's kind of a local thing. It's some local needs. All right, so LPO sigmoid positioned a lot like, as far as the angulation goes, apiaxial sigmoid, just with patient LPO. And we may do a lateral, maybe a cross table lateral, and we'll talk about that here in a minute. And then we'll do what we call a post-evac. And a post-evac is after the patient's discharged as much of that barium as possible. All right, so double contrast is going to include everything in the that we had in the solid column, but we're also going to include some PA and PA obliques, and also we're going to do decubitus. So we'll talk about these individually. We're going to look at the solid column, and then we're going to look at the double contrast. Okay. So, all right, let's do this. Blank slide. There we go. Okay, so your colon, your large intestine, starts on your right hand side. So you got below where the ileum plugs into the large intestine, that's the ileocecal valve. Below that, you got the cecum, or at that point below, you got the cecum. Coming off of the cecum, you got the appendix, right? So you've got a portion of the colon that goes up, and we're going to call that the ascending colon, right? And then you got a portion of the colon that goes from that side, your right-hand side, to your left-hand side, and that would be transverse, right? If you've got an ascending colon, then naturally you've got a descending colon, and then you've got the sigmoid colon all the way at the bottom, and it's what brings you back around to midline before you get to the rectum and the anus, okay? So cecum, ascending colon, transverse colon, descending colon, sigmoid colon, rectum, and anus, right? But where they turn, where the ascending colon becomes transverse colon, we've got two different names for that. And that would be, what's the major organ beneath the diaphragm over on the right-hand side? The liver, right. So inflammation in the liver, what do we call that? Okay, the patient has a hardened liver because of disease process. You get a shot for it. It's a series, 3 shots. Hepatitis, right, hepatitis. So that's going to be your hepatic curvature. Okay, so the ascending colon comes up and it makes a turn. That's a curve, right? So that's going to be your hepatic curvature. Moms or dads in here? Anybody got kids? Okay, all right. So your kid gets gassy. What do you say about them? They got a bellyache. They're screaming all the time because they got a bellyache. We say they've got colic. You colicky baby, right? So colic. I'm struggling here. All right. So you've got the right colic flexure is also the hepatic flexure. If you've got a right colic flexure, then naturally you've got a left colic flexure. Okay, so what do you have over on the left-hand side besides the stomach? What do you have over there? It's a blood reservoir. Spleen. It's a splenic flexure. Okay, splenic flexure, left colic flexure, hepatic flexure, right colic flexure. Okay, so we're gonna have a tendency to think our colon does this, right? It goes up, it goes across, it goes down, but it does not. It comes up, it goes anterior, it goes across, it goes posterior, and then it goes down, okay? So it makes things complicated. If what we want to see is that flexure, what do we have? We have a word for it. something on top of something else. Superimposition, right? So we've got a lot of superimposition there, right? So in order to see those flexures, what we're going to have to do is we're going to have to oblique the patient, all right? So notice what happens, since this is my transverse colon right there, it's as if I'm AP, right? This colon is AP, you are the x-ray tube. Image receptor, okay? So as I rotate up into LPO, what happens to my splenic flexure? Does it get better or get worse? It's worse, right? I mean, we've got superimposition on superimposition, but what happens to my hepatic flexure? It opens up really, really well, right? So again, from AP, if I go to RPO, what happens to my hepatic flexure? It's a mess, right? But my splenic flexure is wide open, right? Okay, so in your solid column, it's easy. You're just looking for where the barium is. In our double contrast, it's still pretty easy. We're really looking for where the air is. But, in your test questions, it may ask where the barium is, where the air is, just like what we talked about in the upper GI series, right? But in solid column, it's just what's open and what's not open, all right? So what we're gonna do for our solid column, again, is going to be an AP, an LPO, some sort of sigmoid view, be it a AP axial or a LPO sigmoid, which is also an axial, a lateral, and then a post-vac at the end. The post-vac is nothing more than just a KUP, just to see how the patient empties. So what we're gonna do is we're gonna do an AP, right? We're gonna do an AP, and that's that's kind of the general survey view of the entire colon. So what you're going to have, in most of our patients around here, we got a pretty big population. I don't mean by a large population. I mean we like a buffet, right? So what you're going to find is that in traditional image receptor sizes, like what are listed in the book, a 14 by 17 might not be big enough for our patient population. So you may have to use the entire image receptor like a 16 by 16. You might even have to, if you're using rectangular image receptors, you might have to do 2 images with the image receptor crosswise in order to get the entire colon, okay? So your AP may be, on a 16 by 16 or with 2 image receptors crosswise, one to include the top and one to include the bottom. Just make sure you've got some overlap. Shoot the first one like the pelvis, right? Put the top of the image receptor at the top of the pelvis, the second one just below that, right? So that you get 2 of them and include the entire colon. So we've got AP, and then we've got, let's say LPO, okay? So LPO, what are we looking for on LPO? Right colic flexure, exactly. So do you necessarily need to do 2 crosswise if you're looking for something very specific in this view, or do you just need to make sure that you get this? Yeah. Well, where is this? Is it high or is it low in the patient's anatomy? It's high, right? So what you might even want to do is position kind of like a KUB, but go slightly above it to make sure that you get the top of the flexure, okay? So go slightly above the iliac crest to make sure that you get the top of the flexure. Realistically, the right colic flexure, the hepatic flexure, is probably not going to be too hard to get. It's not going to be too high because of the position of the liver, right? Liver's pushing it down. So you'll probably be okay if you center at the crest, but just to be sure, you might want to go just a little bit above it. Make sure you get that. Even if you clip this, make sure you get that, right? So you do LPO. If your routine then is to do an LPO sigmoid, then you've already got the patient in position for the LPO, right? So in this case, then what you would do is take the X-ray tube and go towards the bottom of the table, angle cephalic, move the image receptor and include what would be the AP sigmoid and do the LPO sigmoid. So if you're at ETMC or Mother Francis here in town, UT, and Mother Francis here in town, very good chance you're gonna be shooting LPO sigmoid. Really good chance, all right? So since you've got the patient already in LPO, go ahead and hit that, all right? Now you're gonna roll the patient back into an RPO. With the RPO, what are you looking for? Splenic flexure. Right. Now, in addition to all this crossing over, what you've really got in the appearance of your colon is something more like this, okay? Because of the placement of the liver, the right colic flexure is going to be lower than the left. So now, it becomes more important to center a little bit higher for the RPO than what it was for the LPO, right? Because good chance that you're going to, if you position at the crest, there's a good chance you're going to get the hepatic flexure. If you position at the crest, there's a good chance you're not going to get the splenic flexure. Okay, so go ahead and position a little bit above the crest, even if you didn't do it for the LPO. Make sure that you do it for the RPO to make sure that you get the top of the flexure. That's what you're looking for. You're not looking for this over here, you're looking for this, right? So, RPO. All right, now your lateral may be a cross-table lateral. Some of your doctors want a cross-table lateral. It better demonstrates a potential cancer in the retrorectal space. Okay, so they may want you to shoot the cross-table lateral with the enema tip removed. All right, so ask for overheads. You know, do we need any overheads? And if they say yes, make sure that before you get to this point, you've got your routine mapped out. Know your doctors, what they want. You know, if your doctor just wants an AP sigmoid, then you might start with that, right? You may start with an AP sigmoid, shoot that, and then go with an AP, and then go with a LPO, RPO, and then roll the patient back to the lateral. Or you may go with RPO, and then if they're not asking for a cross-table lateral, RPO, LPO, roll the patient all the way up into a lateral position. Move the patient as little as possible. What you don't want to do is this. Remember, your patient population here is probably older, right? So muscle tone's gone. So what you don't want to do is this. Let's see, I'm going to do an AP, I'm going to do an LPO, get this. I'll do RPO, get this. Wait a minute, I got to go back and do an LPO sigmoid. I got to do this. And maybe an AP sigmoid, do this. Oh, I forgot. I got to get them all the way up on their side for a lateral, right? The more you rotate the patient around, the more likely they are, first off, it's just hard on the patient, but secondly, the more likely they are to lose that enema tip. And now you got a mess and an embarrassed patient. Okay, so get all that done. If they want a cross-table lateral with the enema tip out, that's the last thing that you're going to do before you get the patient up and walk them to the restroom. Then you're going to bring them back and you're just going to shoot a single KUB, regular old KUB, post it back. Okay?